There's lots of friends of the Mindwave team. I can see on the participant list, and lots of us that are new to View that are new to us as well. So we're really pleased to have you join us. My name is Victoria. I'm the Chief Innovation Officer for Mindwave. For those of you that don't know us, we're a technology company, and we help our clients solve problems and improve services by using digital technology. We do loads of different things, but one of our core offers is an open source personal health record that enables patients and citizens, amongst other things, to have more control over their data. So that's enough about us. I'm really pleased to be facilitating and chairing today's panel. I'm going to introduce you to each of the panel in turn, and I'm going to invite them to make a contribution, and then we'll have a discussion. So if you would like to ask questions during the webinar, then just put it into the chat, and we'll pick them up as we go, and there'll be time for some to put some of those questions to the panel towards the end. So before I start with our first panel member, and I must warn you, I've got a dog next to me, and I think Pauline's got a couple as well, so if there's some barking, please don't be too distracted. So never has the role of digital in mental health been more important to get right. The mental health impacts of the pandemic are only just beginning to become apparent, and the consequences are just starting to unfold. And we've seen that digital technologies, particularly things like remote consultations, have become a real necessity in this time of social distancing. So this webinar is inspired by a paper that John Torres and his colleagues wrote in the Journal for Medical Internet Research, where he argues that now is the time to accelerate and bend the curve, as he describes it, on digital mental health. So that's what we're going to consider today. What might bending the curve entail, and what might it be involved? What are the benefits, and what are some of the risks? And Janet, who's our chief exec, and myself at Mindwave, we wrote a paper that's on our website, where we put a little bit of a provocation that we'd like the panelists to consider. And there are three possible scenarios, and we've drawn a bit on a paper that Nesta did around potential scenarios post-pandemic. So the first one is that normality resumes. We see some shifts in the take-up of digital, but by and large, things don't get embedded. We tend to revert back to the way we were. We don't get things properly embedded in practice. So that's one scenario. Some small gains potentially, but nothing substantial. The next scenario, and by the way, none of these are mutually exclusive, is a more progressive curve. We are definitely starting to see a rise in the prevalence of mental health difficulties. And in our progressive curve, it galvanises the government to invest more in prevention and treatment services. Digital technologies are a key enabler in personalised, flexible, person-centred care. And we start to see maybe new roles such as the digital navigator that John and his team talk about, that help people access blended face-to-face and digital services. The next we've entitled, again drawing on Nesta, an authoritarian curve. And in this scenario, rather than increased investment, there's actually decreased money available for mental health services. And we enter a crisis of provision combined with increased demand. And stretched mental health services actually have to rely on self-tracking data to provide remote-only services. And really only those with the most acute need have access to, for example, a mental health practitioner. And in this scenario, we end up with predominantly online services. And we have a real problem and a challenge that maybe people who are socially and digitally excluded may find it even harder to access those services. So those are three possible scenarios. It's likely we'll have a blend of the two. I don't want to blow the conversation before we've even started it. So we'll be thinking about what we think is likely, what we think is desirable, and what we need to put in place to get the best possible future for digital mental health. Now, I'm really pleased to start the conversation with Kat. So Kat Jackson, hello Kat. A lot of people will know you as Kat Cormack. You're a community engagement worker at ZenZone, working on Couth and Quell, digital mental health services, particularly focused at young people. And I know, Kat, we've known each other a long time, and you've been involved in digital mental health, both personally and professionally, for 18 years now. And I know that you started on your own personal projects at the age of 13. So you've been doing this stuff a very long time, and you're very interested in participation and co-production. So Kat, I know that you access mental health services. We had a chat about it the other day, and it would be great to hear from you, from your personal experience, what's changed and what impacts that's had on you and your care and support.
Yeah, I mean, it's interesting because, like you say, I've used digital mental health support for a very, very long time now, and that goes back to when I was 13. And for me, digital has really been the only continuous care that I've had over almost 2 decades now. So it's something that I am really passionate about personally and has really helped me. And I find it quite interesting because actually over the last few months, I've been processing how little my life has changed. I also have chronic health problems, and so for about the last 3 years, I've worked from home, and for the last 5 years, I've not really left my small little bubble much. So interestingly, I get support from the NHS, but they were already geared up to do phone consultations with me. So mostly everything that I do has just now shifted over to a telephone call. It was nice. I actually had the option of doing Zoom appointments as well. And I've done the same with my GP. I get my medication ordered and delivered through an app on my phone. And I kind of feel like I am a bit ahead of that curve in terms of my own personal care. But I think it's also struck me how different the experience is from other people who, you know, may not have therapists or practitioners that are digitally trained and know what they're doing. They may not use apps on a regular basis. So for me, it's been a good thing. It's been a really positive thing because without the access to online and phone services, I wouldn't have had any care over the last few months and I would have really struggled. But yeah, it's a bit of an odd one for me because I'm already very much the, you know, digitally converted. This is already embedded in my life.
Do you think there might be some downsides because you are very, you know, you're into digital, you see the benefits, you've already very experienced in using technology and you work in the field. What do you think it might be like for people that are less so, Kat?
I definitely know that for a lot of my friends, it's been a lot harder shift. I think if you're used to a certain level of face-to-face contact and support, maybe the kind of therapy or the kind of support that you need is better delivered face-to-face. It's been that shift has been more of a shock to people around me that I've seen.
Okay. So it's been a mixed thing, but for you, on balance, you found it quite a positive experience.
Yeah, I mean, I think if I hadn't had any services over the last few months, I would have struggled so much more than I have, and it's managed me to kind of keep me going through all this.
And to what extent do you think these shifts in practices are going to be embedded within your service? What's your gut feeling, Kat?
I mean, it's interesting because we felt very geared up and prepared. We are a blended service, so we do offer face-to-face support, but because you know, all our meetings are done virtually anyway. All my work can be done from home. It's actually, we've managed to redeploy our face-to-face staff onto our digital platforms with very little problem. And actually, it's felt quite smooth, and we felt very well placed to almost help others who are struggling with, you know, think even things like the ethics and what security levels you need. It must be a minefield if you're
Yeah.
an individual counsellor coming in, never having used a platform before.
Yeah, no, that makes sense. Okay, thank you, Kat. It's really helpful to have you sort of set the context and start us off. Now, I can't see John Taurus on the attendee list unless any of my other fellow panelists can. So I think we might need to come back to him when he arrives. Now, John inspired this webinar with his paper, Bending the Curve, and he gave a US position on where things are now and where things might be in the future. And Pauline, you did a response, a UK response as a letter to the Journal for Medical Internet Research. So Pauline, you're co-director of the CAMS Digital Research Unit at the University of Manchester. You've been working in health informatics for over 10 years, and you've got a real interest and a focus on mental health. And I know you're interested in wearables, in virtual and augmented reality, and data science. And you're particularly interested in how we might improve health and social outcomes for vulnerable groups. So I would love it if you would maybe focus some of the conversation there. So you wrote a response to John's paper. Could you just tell us the key things that interested you in John's paper, and what led you to do that response?
Yeah, thanks very much, Victoria. So I suppose there were three kind of key messages we wanted to get across in our response to John's paper, and we found John's paper really, really helpful, but we thought maybe there were some aspects from a UK perspective that were missing in his original paper. So the first message that we wanted to get across was to really echo the importance of evaluating apps and digital health technologies, particularly around clinical effectiveness, data security, usability, and user experience. And we wanted to talk about some of the UK initiatives in this area. So for example, in the UK, we have the organisation Orca that's involved in health app evaluation reviews. We have the NHS Apps Library that's a place to find trusted apps. We have the NICE evidence standard for digital health technologies, which can be used by developers and commissioners to help guide digital health technologies. So that was kind of the first area around app evaluation and digital health technologies evidence base. Then the second message that we wanted to talk about in our response was to really echo the thoughts of John and his colleagues and express our concerns around equity and accessibility of digital mental health technologies. And this relates, of course, to making digital health technologies accessible to vulnerable groups as well. But we wanted to highlight some of the positives as well as the negatives of using digital technologies. So on the one hand, we obviously want to be very careful not to exacerbate health inequalities by using digital health technologies that might not be accessible to everybody and that might have different outcomes for different groups. But then on the other hand, we were noticing how digital tools can make some things more accessible to people who can't or maybe don't want to engage in face-to-face services. And then the third message that we wanted to get across in our response was around how do we embed the digital technology sustainably in services. And this is where we were thinking about where is it possible to embed new technologies using some of the frameworks that are coming to light and some of the things that are being talked about more widely in digital health technologies in the UK. So things like the NAS framework for implementing technology in complex systems, and using digital learning health systems as a way of embedding and having ongoing continuous improvement and evaluation cycles in services. So they were really the key messages that we wanted to respond to John's paper about.
Okay, and could you just say a little bit more about the NAS framework? Because not everyone will be familiar with that, and I think that's a really interesting framework for us to think about when we're talking about non-adoption of technology.
Yeah, thanks. So I guess one of the problems of digital health technologies that people have been aware of for a long time and has been written about extensively in the literature is that often great new technologies are developed, but they're not sustainably embedded in the settings they're designed to be rolled out into. So the NATS framework provides a really helpful way of thinking about technology implementation and provides us a framework to think through non-adoption, abandonment, scale-up, spread, and sustainability. So how do we understand complex systems with all the human complexities and the technology complexities, and how do we embed things really sustainably into systems? And it gives us a way, I think, of categorizing some of the difficulties and then thinking through how we might address them in practice.
I think I'm always struck by there are some technical challenges, but actually many of the factors are human factors and human challenges. And I've seen some interesting challenges around some of the current, not particularly digital mental health, but health technologies that are being promoted at the moment in response to COVID as being very tech heavy in their focus and not necessarily paying enough attention to some of the human factors, for example, in contact tracing.
Absolutely, completely agree. I think we're often too focused on the technical aspects and not enough on the human elements.
Yeah. And never is that more important than in mental health and well-being as well. Okay, so Pauline, from your perspective, what's the most desirable scenario for digital mental health after the pandemic?
I think the progressive approach, the progressive curve is obviously has many desirable aspects to it. I would caveat obviously that the desirable scenario shouldn't include a huge increase in mental health difficulties that's described in that. Obviously that's anticipated. I think there are many elements though of the progressive curve that are desirable. I think for me though, one of the most important things is that we build a digital mental health system with the people, and talking again about the people involved, that it's being designed with the people in mind. So co-design and co-production for me are key in the development and design of any digital mental health system. I'd really like to see a digital mental health provision where there's equity of access to digital resources. I think an augmentation model is really important. So obviously not trying to abandon all face-to-face services either. I'd really, on the technical side, like to see digital tools being designed to be interoperable, so interoperable with existing health and care systems. We know that a lack of interoperability has been a huge technical challenge against lots and lots of digital health technologies that have been developed for a very long time. I think COVID provides us with some new opportunities. In Greater Manchester now we have the Greater Manchester Integrated Digital Care Record, and that's bringing together health and social care data for all the population of Greater Manchester. So it'd be brilliant if we could use these new resources to build digital mental health technologies that can be informed by much broader and richer data sets than ever before. And related to this, it'd be great if digital tools can employ kind of common frameworks and common standards. That means data could more easily come together and then be more easily analysed across different systems. I think that's been one of the weaknesses in digital health tech so far, that people are kind of designing in silos and then systems can't talk to each other. So that would be fantastic. And lastly, just the final thing I'd love to see, coming back to the human element, is more digital navigator models and digital champion roles across services generally.
So Pauline, could you describe what you mean by digital navigator and digital champion role? Because people, these sorts of ideas are beginning to surface a bit more, but not everyone would be familiar with them.
So we're just beginning to trial the digital navigator role in Greater Manchester Mental Health. And what we're trying to do is to encourage the role of the digital navigator to help with some of the evidence-based evaluation of digital technologies and services, provide some help in selecting the right apps and the right digital technologies for services, do some of the troubleshooting. So when you introduce new digital tech into services, inevitably there's going to be problems and technical challenges, and having a go-to person that can help talk clinicians and other people through those challenges, I think, is really powerful. And finally, helping to summarize some of the data that's coming out of the digital tech and how is that useful to clinicians and other people working in services. That's what I see the role of the digital navigator doing.
Great, and hopefully other colleagues will comment on that sort of role as well. So you've set out a desirable scenario for Pauline. I'm going to ask you to be a little bit more, what's the word? Tell us what the likely scenario is. What do you think's probable?
I think this is a really difficult question. I'm an optimist, so I'm hopeful that some of the developments that are happening now will continue as commissioners and services, and most importantly, people hopefully benefiting from some of the digital mental health tech see value in it, and that there'll continue to be investment. Some of the offerings that are now being made available in Manchester, for example, Cooth and Blue Ice and Silvercloud and other things, they're now widely available. Hopefully, some of these things that are now freely available will continue to be freely available. I think that as digital mental health starts to become embedded, that people will appreciate the need for investment in digital training and digital navigator roles. Hopefully that will become more evident than it has been in the past. I'm hopeful that it will continue to grow and expand and augment face-to-face provision and enable more personalised, flexible care. But I don't think this is going to be a straightforward path, unfortunately. I think there's going to be lots of bumps along the road and lots of learning to happen. And hopefully some of the things like the NAS framework and the digital learning health system frameworks can help us understand and embed continuous improvement along the way.
It does still feel like we're in the foothills of digital mental health, and there's a long way to go and a fairly uncertain path for sure. Pauline, thank you so much for those reflections. We'll come back to you. James, where are you? Hello, James. So James Woolard is consultant psychiatrist for Children and Young People's ADHD service and Chief Clinical Information Officer for Oxley's NHS Foundation Trust. And I think I've got your job title right, but I might not have it right, James. You're also Senior Clinical Advisor for Digital Mental Health at NHS England. Is that about right?
A National Specialty Advisor. I knew
I'd get it slightly wrong. So James, it'd be really helpful to hear, we've heard from Kat from her experience of accessing services, we've had an academic's perspective from Pauline. It would be really good to hear about your practice experience working in a service. What's the impact been on the service and for the families and children that you support, James?
So I think in terms of the impact on us as a team, we were a pretty kind of digitally ready team anyway. We'd been developing a PHR and using a personal health record for many years, well, for the last 2 or 3 years. So we'd already started to kind of do quite a lot of remote consultation via that interface. and we obviously use telephone appointments quite frequently. What it has done is we've started to use Attend Anywhere now for video calls, and that's come online in the last few months, or the last month or so, and we've been using that to do assessments. And it has its limitations. What we've not been able to do as a team really, which has limited the amount of service that we can offer, is the physical monitoring. And there's some really exciting techniques, perhaps useful in adult populations, that haven't been calibrated for young people, in terms of using mobile phone cameras to detect pulse and heart rate. I think that's exciting, but just out of reach of this particular moment in time in terms of helping us with response. We've been using Microsoft Teams, and everything, all our team meetings and process have been virtual. So I think as a team we've responded quite well. Having said that, there's been some technical issues, and my team spent a few hours here and there on the phone to IT trying to get stuff to work at home, which has perhaps been one of the biggest obstacles to overcome. In terms of the young people and the families that we've been looking after, I actually think it's been a really mixed picture. We've been trying to support the ones that we know are the most vulnerable. You know, these are the families at home, perhaps with lots of children, who have, you know, perhaps 2 or 3 children, all who've had difficulties, perhaps, you know, learning difficulties or autism or ADHD, trying to support those families with a bit more kind of intense kind of support, often via the telephone, sometimes via the instant messaging functionality we've got on our PHR. So we've been trying to focus on those families that we know need our help the most. We have a lot of families who seem to have just coped really well. In fact, we have a lot of children who seem to have or families who've decided to take their children off medication whilst they've not been at school, because it's actually the school that provides quite a lot of the stress in terms of helping them manage their concentration and focus and mental health more generally. In the absence of that, I remember one particularly young person commented to one of my colleagues, you know, staying at home all day, working, sitting on my couch, doing stuff on a computer, that's what I was built for. So I think there are some young people who've adapted really well. Having said that, I think there are some young people who have really struggled and found it hard in terms of the breakdown in routine, not being able to get out, and particularly you got younger children who like to have space to run around. And I think it's really highlighted for me the sort of underlying social inequality we have in places in the area that I work, where you've got families who don't have access to outside space. And those few weeks where it really wasn't okay to go out to outside space, I think were quite hard. You know, those families who have gardens with trampolines in seem to have managed slightly better, if I'm honest. So I think, it's been a mixed picture in terms of how families have responded. Overall, I think like a lot of services, we've seen lower referral numbers, lower telephone calls overall. And I think that's because schools are not there. So that, again, as a source of anxiety and stress for young people, particularly that we look after, as school isn't there and teachers aren't phoning us up saying so-and-so had a really bad day today, what's going on, can you offer them more support? That's kind of quietened down a lot as well.
And how much do you think that the changes that you're seeing will be embedded, James, or how much do you think they'll sort of revert back to how they were pre-pandemic?
So I think from our point of view, what's going to be really interesting is just taking a step back from health for a moment, is looking at education and thinking about how can education be provided differently. I think there's definitely a social role for schools in terms of giving people, young people, an access to a social environment. But some young people find that environment really challenging, and actually, receiving schooling at home via live video lessons and so forth may have actually benefited for some. So I hope that education, as much as we might talk about health over the rest of the next bit of the hour, education might have some lessons to learn here, which could be really helpful in helping us support the mental health of young people. In terms of more widely, I think the rest of the organisation, I think in general, it patchy uptake across mental health services, in terms of, certainly in my own organisation, thinking about, there have been some teams who've really taken it on board, particularly in our some of our services like occupational therapy and physiotherapy, who've taken video and understood they could use it to do things differently. We've had other services who wanted to continue delivering in the same way, but with, you know, the added protection of PPE. I guess that's what we've got to find out, is what's right for each individual service in terms of meeting their kind of service user or patient needs.
And have you touched on digital sort of exclusion, and I'd just like to push you a bit more on that, because there tends to be assumption, and you're working with families with young children, that younger people are more digitally savvy, but you talked about that inequality, and I wonder whether it's more, people tend to think about it in terms of, does someone have access to a smartphone? But of course, it's much more than whether you've got access to a phone or broadband. It's also about trust and confidence and motivation and just basic literacy. Has that become more apparent to you?
I think most, I certainly remember the sort of video calls that I've done sort of more recently have been sort of supported by the young person helping their parent access the particular platform. So I think there is some reality. One of the things that I think is quite interesting is, and we've all had to face it as professionals in terms of, you know, hour-long Skype meetings with 20 odd people, is some people just aren't comfortable doing video consultations in terms of appearing on camera. So I think I'd also be I think there's a sort of working with people in terms of taking it a step at a time. Video can be so helpful when we're thinking about assessment, in kind of seeing the family, not just talking to them over the phone, but seeing them in terms of seeing how they interact over the, you know, down a video call and so forth. So I think, yes, there's a bit of literacy, but most of the platforms we're using now, particularly like Attend Anywhere, actually require very little. They're very familiar in that sense. They feel like other platforms we're using. And I think that's what I've seen, you know, people have become very familiar in terms of Zoom and so forth. In fact, that's been a challenge, really, that some of the platforms we've used in the past haven't had that usability, which has reduced the barrier.
Yeah, that's I've heard a few people say that. That's really interesting. We've got some great questions coming in, so keep popping them up, and I will I'll pick them up shortly. Pauline, I'm going to give you a job to do, if that's all right. Someone's asked what the NAS framework stands for. I wonder if you could just cut and paste the link into the chat, please, because it's a bit of a mouthful to repeat. Okay, I'm going to ask you, James, just before we move on, about what you see as a desirable scenario for digital mental health from the pandemic, and also what conditions you think we might need in place, given that you have an NHS England role as well, in terms of the right conditions that would enable some of the gains we make to be leveraged.
So I think the thing that we need over the next month, maybe even 2 months, is a period of intense reflection and structured reflection. And I posted earlier on Twitter, in anticipation of this webinar, a RSA, Royal Society of Arts and Crafts article on thinking about reflection. That's something my own team and own organisation have been thinking about, in terms of what do we need to keep doing, what do we need to continue to adapt, and what can we stop doing in terms of our response to COVID. So if there's one wish I have for the system, it's that we don't simply stop doing digital because we're trying to get back to normal, and actually we take the time to reflect. And I think cultures and practices are so important, and reflecting on those cultures and practices and thinking about what we can change, because I think there's going to be a magnetic pull back to what we would, you know, the emotional magnetic pull, trying to get back to what life was like pre-COVID. And I think we've got to try and hold on to that and resist it in some fashion long enough to reflect. And I guess I think that's the most important condition, is reflection, and that builds that learning healthcare system. That might be driven a bit by good data, and I think organisations, certainly mental health trusts, are thinking about what data they need in order to kind of inform those decisions. So I think that's really important. Patient feedback, professional feedback, process measures, and all that as well. I think what's likely is that will continue to be uneven, unfortunately. And I guess that's the work that we've got to try and do collectively, is try and even it up for everyone, both in terms of professionals and patients.
Someone once described service improvement or innovation with the NHS as like trying to fix the car while the engine's still running. And I just wonder how likely it is we will be able to create that reflective space and evaluative space to really understand what's worked well and maybe what hasn't worked so well and that we ought to ditch.
I think there's that thing about, there's a danger that the kind of idea of technical debt and that you need to spend sort of 20 to 30% of your time dealing with the technical debt that you've probably built into your systems and processes. If there's ever a time to make sure that we give ourselves 20 to 30% of our time to deal with the technical debt, now is it, so that we don't. And I think it's about preventing those vulnerabilities being there over the longer term. Heaven forbid we should get an extensive, reinfection wave 2. I think we need to address those vulnerabilities.
Thank you very much, James. Now I'm going to turn to Chris. So Chris Hollis, you're Director of Mindtech. So you're a technology cooperative at the University of Nottingham that, as the name would suggest, specialises in digital mental health. And you're also a child and adolescent psychiatrist as well. And you're particularly interested in digital mental health in respect of ADHD, Tourette syndrome, early onset diagnosis schizophrenia, and various other mental health related things. Now, James started to touch on the topic of evidence, and I guess one of the interesting things we're ending up with potentially is a proliferation of technologies in use in mental health services with variable evidence, and some of which might fly and some of which might not. So could you just tell us why you believe evidence is so important in this sphere to start off with, please, Chris?
Yeah, thank you, Victoria. And it's great to be part of this discussion. It's really important. I mean, in some ways, it's quite fortunate to hear, to come after Victoria and Kat and James, because I agree with virtually everything they've said. So I have to think of something that's kind of slightly different. But I think for us, the issue of evidence, John pointed this out in his article, and Pauline, that's crucial for establishing trust and credibility. And I think the digital space, we know, is full of, sort of thousands of tools and examples where really that evidence doesn't exist. And that, in a way, undermines the effort to improve mental health services and digital delivery. But I guess in this, just to step back in terms of this kind of COVID crisis, one of perhaps the first things in evidence is that we're really clear what the impacts are, particularly in terms of mental health. So we don't rush ahead of ourselves. We may anticipate what they are, but we do need the research to tell us, particularly who's affected and why they're affected. And that will actually help us direct interventions towards those building resilience, but also the kind of causes, the things we talked about, James talked about in terms of schools and in isolation and entrapment, losing social contacts, etc. So I think we do really need that evidence of the impacts of this crisis and the lockdown. I think secondly, the issue of building evidence is really critical, and the video conferencing is a really good example of that. And John wrote that we had evidence. But I think we have a fantastic opportunity. It's like a natural experiment that's going on at the moment. I've heard some trusts saying, we had, a handful of video conference calls, over a year, and now we have 10,000, in a couple of months. So there's a huge amount of data and an opportunity to work out who it's working for, who it's not, what the training requirements are, what the risks are, because there are risks in terms of things like privacy, and for some people it's very difficult to have the right context to do that work, but others, it's entirely appropriate. And I think what we're going to move to is something that's not a one-size-fits-all solution. That's partly the problem has been with digital, is that we expect everyone to take it up the same way. We have one intervention that we expect everyone to utilize it, and it won't work as well. So I think research is incredibly important. I'm not sure that it's going to happen, actually. I'm not that optimistic, but I think there are opportunities. But sort of action research in practice is often quite difficult to do within the NHS, but I think we really need to do it. And I think the third aspect that I guess I'm concerned about is are we just going to invest potentially into things that they're not that effective, but also don't really change the system, the embeddedness of digital in say, particularly in NHS mental health services. Because I think the really exciting thing about the last few months is that the service I work in and mental health trusts have had to change and had to adapt in terms of staff working with digital in the way they didn't before, and not outsource it potentially to our other providers, because you know, this may be a slightly challenging view of things, but I think we have done a lot of outsourcing of mental health services within the UK, and that's led to silos of provision. It's been much more difficult to integrate that, and to some extent, some cherry picking of where the provision has been delivered, and in some ways, avoiding some of the more complex and difficult problems in mental health services. So, you know, that is something that I think needs to be really addressed. Is it really are we going to get really different, particularly core mental health services, or will we just get a proliferation of more slightly outsourced, slightly siloed mental health platforms and provision?
So those are some really big questions that the evidence can contribute, but takes a policy response as well, presumably. So is there something about how we, you know, we've got tech companies, we've got clinical entrepreneurs, we've got the NHS, we've got policy bodies, Department of Health, NHSX, and academics. How do we bring everybody together to try and sort of create the best possible scenario? Because there are a lot of different players, aren't there?
Yeah, absolutely.
And space, particularly for tech companies trying to work in this space.
Yeah, and you're absolutely right. It's a complex, you know, we talk about an ecosystem or, you know, this sort of complex infrastructure. I think it does need a strategy. I don't think we have a digital mental health strategy. I mean, James may disagree with me, but I think fundamentally, Pauline talked about a great place to be, but it's also how we get there. You know, how would we actually get to that place? And how would we avoid perhaps slightly short-term knee-jerk responses, which would be to increase investment into perhaps not very evidence-based provision that perhaps doesn't actually address some of the really critical areas of where the mental health morbidity is increasing and difficulty is increasing. So I think James's idea of certain point of reflection is actually quite good, because, you know, this is going to be a marathon and not a sprint. This is going to be quite a long-term view. I think we have a great opportunity, but we could get it wrong as well as get it right. I think industry is critical in terms of development and innovation. You know, the whole of the NHS is populated by industry products anywhere you go. The question is that they're embedded within services. And we have to think about the services. These are tools and technological tools that augment and support, but they will only work within that context. And I think that's, you know, what Pauline's been talking about. But I don't think we've really grappled with that properly particularly in the NHS. I know the NHS isn't the only place where mental health services are delivered, and it shouldn't be. But I am thinking about, you know, are we going to address this really huge unmet need? We know that, you know, 3/4 of young people with depression don't get any help at all at the moment, and they have significant mental health problems, probably sort of 2/3 of adults. So we need to address that population and not find that we're putting resources into those that may have, you know, concerns and interests, but aren't actually at the core of where mental health services, I think, need to target.
Okay, thank you very much for that. So the case for a period of reflection, but also for a more strategic approach to digital that takes into account these different actors within the system, and is also not piecemeal.
I think yeah, that's right. And a place where, you know, as you said, those players, those stakeholders can really come together, develop a pipeline for evidence, the co-design, production, and implementation. I don't think we have that at the moment. So that kind of system that we need to create, I think, is where we need to go.
Thank you, Chris. James, could I get you back? You've turned your camera off. I wonder if I could retrieve you for a moment. Oh, hello. So we were, so Chris sort of ended there talking about co-design, and I know it's something that Kat's very interested in as well. Simon had to cancel joining the panel at the last minute, but Simon leads on user-centred design for NHSX, and he also leads on mental health. And I know, James, in NHSX's and NHS England's response to digital mental health, there's been a lot of work done to really understand user needs. And it would just be, could you maybe just say, I know I'm putting you on the spot here because you weren't planning to say this, but would you be able to just say a little bit about what's been done? Because I think that would be really interesting to the people on the webinar to hear about that sort of user-centered design approach that's been taken by NHSX.
Yeah, so I think Simon and Rob Benathi, who's I think maybe one of our attendees today, have written a blog on the process that we've been following. So I can post that later, just to be helpful. And I guess so in terms of the process that we've been following, it really is to try and understand as quickly as we can the user needs around for young people, particularly in this first phase that we've been working on, but we're moving on to other groups, is what are their needs, what has changed, what are their pain points, if you like, in terms of accessing services, getting help, supporting themselves, and then how can digital respond to those. So it's not saying that digital is the solution immediately, and I think that's one of often the difficulties we have within kind of chat around digital, is that we kind of solutionize, we produce the solutions and then go looking for problems. This was very much trying to understand the kind of user research, the user needs, and the research shared some really helpful insights for me. And I guess I hadn't reflected on this, but actually it's something I've taken away to my clinical practice. Privacy is a massive thing when you're stuck at home, both privacy for your parents, privacy for young people, and actually whether or not a digital tool will be used by a young person or a parent, if they're accessing their own mental health, will really depend on whether it helps them preserve their privacy or can be managed in a privacy preserving way. That was the kind of insight that I think really helped us think about what might be helpful and what might work, and then in terms of thinking about implementation. Obviously one of the other user groups in this space is clinicians and professionals, and confidence was a key theme as well, that whatever we put out into the system, professionals had to be confident about using it with families and young people. So those were two sort of elements that the user research did. I mean, it was kind of the normal user research that other people might be familiar with, going out and trying to get in touch with young people, professionals and so forth, and families and parents, and talking to them about how things are, and simply asking those curious questions about how things are, to identify those pain points. And then some beautiful graphic work by some of my colleagues in terms of picking out those pain points across service pathways, which I hope we can share at some point, in terms of really putting it together and helping you see how, Chris talked about the ecosystem, seeing that ecosystem.
Yeah, thank you for that, James. Kat, I'm going to come back to you. So you started us off talking about your personal experience, and you also work for a tech company. So it would be really interesting, just before we go into the discussion, and we've had some brilliant questions. I'm trying to do a lot of multitasking here. It's very challenging, reading the questions and listening to your contributions as a panel. But what have you seen as Cuth? Could you give us some reflections on the current scenario and what it's meant for your organisation?
I mean, I saw a joke the other week that the increase of the word unprecedented is unprecedented, and it's really hard to know what else to say. I mean, the number of users coming to us across Cuth Student and our adult service Quell is staggering. So I would say, in terms of moderation, not even the counselling side of our service, we're getting about 20,000 submissions a month at the moment. The majority of this is all on one discussion, and it's been a really interesting time for us. So we've seen real shifts in the way people are using our service, what they're talking about, what they're seeking in terms of support. I think Cuth's had something over a 30% service increase over the last couple of months. So trying to, I think, manage the kind of capacity when a lot of our users are saying, we've got nowhere else to turn. The schools aren't open, we can't see our friends. I think the thing about privacy that's been mentioned is really important, and the idea of being eavesdropped on if you're on a therapeutic call. So actually all of our contact is done by instant message, and a lot of the users, they'll do it in the privacy of a room in their house, or they can do it without, they can do it in a room with their family, and people don't need to know, and that's always been really important. we've definitely seen a shift where before our users mostly came on after traditional service hours, so 9 to 5 p.m. they come to us, and it feels like it's more constant now. Where they're online for school and really struggling with that, it's easy to pop in and just go, oh, I'm really not coping, and kind of have a little vent. I think as an organisation, we really want it to be the progressive curve. What I kind of see is like this sharing and caring curve. I think it's, you know, it's a really nice idea that would be around offering choice to people, so they can use phone or face-to-face, or they can use Zoom or instant messaging and what suits them. So, I mean, it struck me that we're having an event on digital mental health, and if this had been held face-to-face, I wouldn't have been able to attend. So actually there are all sorts of indirect benefits that probably aren't directly related to mental health products and services.
Yeah.
I think digital has always been on Kids a really safe space for our users. We have a really high proportion of BME and LGBTQ users. So I do hope that, you know, the progressive curve for me would be making more available to more people and not shutting things down so you can have face-to-face or telephone. Actually, there have been times in my life where I've not been able to do face-to-face or phone, and actually having that choice is the only way I've maintained my health and my care. I think it's easy to talk about a worst case scenario, and the word data gets thrown around a lot, and then when you ask what people mean by it, there's a lot of blank faces. And so the way that the public hear about data tends to be big and scary and about it being sold to other people. And what I've seen over the last few years is this tech for good movement. I'd really like to see a data for good movement, where people are sharing what they have, being less precious about that data, and using it in research and doing really great things with it. So I mean, on the ZenZone website, we have been putting up regular reports with insights, qualitative and quantitative data around COVID, and we're sharing that with Public Health England. And just, I hope if there are enough good people who, like Chris said, are willing to take part in this marathon and actually stay the course, that we will be able to embed some good out of this, and it won't just be normal with a bit extra.
Thank you, Kat. And I guess you're speaking to Chris's point as well about real world evidence, and it's great that your organisation is generating evidence that we can all make use of and learn from. I'm going to turn to some questions now, and I'm going to come back to Pauline for a question from Alex. And he asked a question which I think a lot of people have concerns about, which is how we see mental health provision via digital affecting clinical and patient interaction. And I know, Pauline, in your response to John Torres's article, you actually talked about some of the surprising benefits actually of online interaction, but could you maybe just share some reflections about the sort of patient perceptions of services and that relationship and what digital might do to it?
Yeah, I mean, I suppose one of the points by John in the original article as well is that it's not digital or face-to-face. It can be a blended approach, and digital is not for everybody. Face-to-face is not for everybody. I think Kat's mentioned that as well. I think patient perceptions of digital interventions are different as well. So, you know, we get feedback, different feedback based on the different tools that are being used, based on the different individuals using them. So there isn't, I don't think there's a simple answer to that question. I think it's a combination of how it's implemented, which tool is being used, what the individual perceptions are. I don't have an easy or quick answer, I'm afraid, to that one.
That's okay. I'm going to, rather than get everyone to answer, I'm going to sort of move about with questions. We've got a great question from Mike Chitty. This is a good challenging one for people to reflect on. So does digital simply maintain and sustain existing clinical power structures? And we've always had issues around paternalism, haven't we, within mental health? James, I think you might want to respond to this one. Are we just sustaining the status quo, or can it actually help transform patterns and power structures so that we're less dependent on clinical power and maybe a more deficit-based approach? So do you think there's some potential there? And can digital do that on its own, really, or does it have to be part of a wider systemic change that digital might just be a contributor to?
So I think, you know, let's define digital mental health as the cultures and practices of mental health care in the internet age. That's kind of my working definition. And I think absolutely it's about cultures and practices. I've mentioned it earlier, and that's cultures and practices are where power structures get formed and reformed, and I guess technology can make it possible, and I'm distinctly using the word technology, not digital. Technology can make it possible for those to challenge those power structures, but it's still about a conversation between people, and a communication structure that kind of, you know, bubbles up in people, in groups of people who come together around a problem. So I think, and I take the kind of the digital processes is really focusing. It's a very empathic process, isn't it? Design in digital spaces is a very empathic process. Understanding user needs. Now, actually, that's a core concept to mental health services for many, many years. And we talked about, you know, patient-centered care in healthcare, but certainly in mental health care for many years. I think what's going to hopefully change is that we have the technologies that allow information to be shared much more easily, that it doesn't get locked down in electronic records that are simply owned by professionals, but that there are shared spaces online that allow us to kind of challenge some of that. And I think that's going to be uncomfortable for some on both sides. And I think there are some new skills that professionals are probably going to have to develop around conversations in terms of challenge, but also and kind of being open enough and vulnerable enough. I go back to Brené Brown's idea of vulnerability, which I'm quite keen on. You know, I think Brené Brown's idea of vulnerability is a core concept for going forward in terms of digital transformation.
Thank you, James. And I think you answer Alice Cole-King. Hello, Alice. You answer Alice's question about some of the rebalancing, because actually you have professionals who might not be that confident with technology working with people accessing their service who are. So there's some interesting sort of redrawing of lines. Kerry from Kooth says she believes that there is the potential to disrupt power structures, and actually peer support, empowering people to access counselling on their terms when they want to, in the way that they want to, is actually quite transformational. Chris, any thoughts on this sort of transformational and maybe disruption of power type idea, either from your practice or...
Yeah, it's a great questions. I mean, just to pick up also James's point, so when it comes to sort of having your own data, because that's also something Kat picked up. So if you've got wearables, you've got apps that sort of you can track your own progress and symptoms and sleep and relate it to events in your life. That gives you a lot more information about yourself and about your condition, which previously perhaps you didn't have. And then I think the key decision is that you decide who to share it with. And there's a big debate going on at the moment around, say, the COVID app and you know, where data is located and how centralized it is, or how it's kept. And that's something we need. If we're going to maintain trust and get uptake, that's going to be critical. I think peer support is obviously absolutely critical, been affected hugely by lockdown. But we do need to, at the same time, you know, study its impact of the interventions as well, because and it needs really good moderation. You know, often that works well, but moderation is not simple, and you need to think about potential risks as well as benefits too of that. So it's great, but not it's something that just needs to be thought through and well supported.
Thank you, Chris. Kat, anything you'd like to comment on? Because I know that's really a really important issue and concern for you.
I mean, yeah, thank you for acknowledging that moderation is not a simple task, and especially not with I think the level of risk that we're seeing at the moment, and trying to make sure that our site is a really, really safe place for everyone to. I mean, for me, peer support is huge. I think it's another one where with digital, you have to be careful about how you portray it to the general public and to patients, and you have to make sure that you're getting the right reasoning across. So I know that sometimes backlash can be, you're doing this because it's cheap, or, you know, you're doing this so you don't have to deal with me. and you know, issues around data and people's trust around that. So I think peer support is great. I think there is some evidence around it. It's certainly, like, anecdotally for me, it's saved my life. I would love to see it taken more seriously and embedded in more services, but I think it's always that balance of, you can't be replacing something else. You need to have professional oversight at points. You need to have safeguarding processes in place. I think it's something that the big tech companies are probably struggling with a huge amount at the moment, especially when the pandemic kicked in and you saw Facebook having to send its moderators home and relying on more AI, and that not working out too much. But yeah, it's a very, very interesting times. Very interesting times in peer support, I think, as well, having that awareness that for the first time, certainly in my lifetime, we're all going through exactly the same thing, and that you can't pour from an empty cup, and you need to be really careful about your own mental health and supporting others.
That's a really nice way to put it, Kat. Thank you. Listen, we have got so many good questions on the chat, but we've run out of time, and also some really good links and sort of back and forth. So I'd encourage people to have a look at it. We have recorded the webinar, so we'll send it to you via Eventbrite once we've downloaded it. I'd just like to finish, panelists, by asking you each in turn, just 30 seconds, if you could pick one thing that you would think would be really pivotal to put in place. So I'm not asking you to predict the future, but what's important to put in place that's really going to help us bend the curve on digital. Pauline, what's your one thing? I feel like I'm on Desert Island Discs now.
A really clear research and innovation strategy across services.
Fabulous. Chris?
Yeah, thanks. I think a commitment that we have, you know, core NHS digital mental health services that are widely accessible and equitable at the centre of our mental health services. They're blended, but they no longer need to be called digital. They just become what the new mental health services are.
Thank you, Chris. Kat?
I mean, I hope we don't return to normal. I hope that this is the start of something new and hopefully better and more accessible for everyone.
Thank you, Kat. That's a good one. James, sorry. Not John, I apologise. I was thinking of John, but I meant you.
So I think the thing, and I've said this for a few years, which is, and now is the time to do, which is that on every care plan or during every care planning session, you know, professionals simply ask two questions. How can technology help you live your life in a mentally healthier way? And how can technology get in the way of you living a mentally healthy life? And it's just those two questions open up, and curiosity from clinicians is all we need, because the tools are out there. We just need to ask those two questions when we're thinking about how we can help somebody, and I think that will be the game changer.
Thank you, James. Now, I know John wasn't able to join us, but he doesn't know it yet, but I am going to interview him and record it, and I will send it to you. So you will get John, even if you haven't got him on this particular webinar. I'm going to just finish up by a lovely message from Kenneth McLeod, who said, "Thank you. There are new horizons to aim for. It will never be the same again." That feels like a good place to end. Thank you very much to our panelists. We can't clap them, can we? But I will. And thank you to all of our attendees. We really appreciate you joining us. And as I say, we'll send the webinar recording out to everybody. So stay safe, enjoy your evening, and thank you very much. Cheers. Thank you, everybody.